I am delighted today to remind all of you that we are here through the generosity and vision of our Shoppers Drug Mart stores in the region, who provide a wonderful grant to enable this program to be carried on. And I'd like to invite Shama Acharya to come forward at this time to give some remarks. Shama is not only representing our sponsor today, but she's a member of the Women's Giving Circle and associate store owner of the Shoppers Drug Mart in downtown Kingston. She's a native Kingstonian, having returned to the city after 10 years following graduate school and some time in Toronto specializing in psychiatric pharmacology. And we've asked her to come forward and just bring greetings on behalf of our sponsor. So Shama.
I'm very happy to be here again. Thank you so much, Denise, for that nice introduction. I am very honored to be here as the representative of Shoppers Drug Mart. Our organization has a strong focus on the health and well-being of its local community, with women really at the epicenter. Actually, as of 2015, I just found out that Shoppers Drug Mart has committed their National Tree of Life campaign to be exclusively focusing on women's charities, with the ethos of improving the mind, body, and spirit of females all across the country. In the more global spirit of raising the wellness of our shared community collective, I honestly can't conceive of a better group than the Women's Giving Circle, and indeed the University Hospitals Kingston Foundation that epitomize these shared visions. Thank you again on behalf of Shoppers for allowing us to participate, and I'm really excited to hear about the local research that we'll be funding, and we'll see you again in the fall. Thank you.
So as many of you already know, we're a group of diverse community women who together are able to do more than individuals, as individuals. Our goal is to build a sustainable fund to support patient-focused research in Kingston hospitals. And last October, our members were asked to vote on an area of research that we would like to see funds from our Women's Giving Circle directed to, and I'm pleased to announce that the area of gastrointestinal disease was chosen. Today we will hear from 3 successful grant recipients. So please continue to enjoy your meal while I introduce our first speaker today. Dr. Elaine Petrov completed her master's degree at the University of Ottawa, her MD at University of Toronto, and she then moved to Chicago, where she did her internal medicine residency and completed her infectious disease and clinical pharmacology fellowships at the University of Chicago. Elaine received a Clinical Scientist Career Development Award from the NIH while at University of Chicago to pursue research in probiotics and gastrointestinal disease. These studies formed the foundation for her current research program at Queen's, which is focused on understanding the human microbiome and its role in health and disease. Please join me in welcoming Elaine.
I'd just like to say, first of all, thank you very much for the opportunity to come here and speak to you today. I was asked to give an overview in sort of a broad sense of the research interests in our lab and what we do. And really what we work on and are interested in is the human microbiome, which you may have. Has anybody heard of the microbiome? Okay. So this has garnered a fair amount of interest, both in the scientific and lay communities, fairly recently, actually. And part of the reason for this is that it's only recently really been appreciated, the fact that we have, for every eukaryotic cell in our body, we have 10 bacterial cells. So we're sort of, there's an expression that one of my colleagues likes to use, that we are the spaceships for our microbes, and that we're basically just a big incubator for all of our bacteria. And we work as a symbiotic organism with our bacteria. So I think that wasn't really appreciated before. We all know about how there's the bad bacteria, but there are actually a lot of good bacteria that have co-evolved with us, and they serve a lot of beneficial roles as well. And so if you look at the microbiota, So this really starts at birth, and as we grow, our microbes evolve with us, and they change in terms of the composition and the proportion as we age. And this is sort of, does this swing over? There we go. This is sort of also illustrated in sort of broad terms with this slide, where we have, there's four groups of bacteria labeled in those different colors over there that you can see how the composition changes and shifts as we age. And so when you start off, you end up with a very low diversity, and as you develop and grow, the bacteria sort of bloom and you develop a more diverse collection of, or ecosystem of bacteria, and then this starts to decrease in diversity as you get to older ages. And different things that we do will perturb that system. So antibiotics, for example, will decrease the diversity in our gut flora. And this has some implications for disease. And that's just sort of illustrated here. C-section versus vaginal delivery, for example, we know that makes a big difference on what we have in terms of the bacteria in our guts going forward in life. Whether you're breastfed or formula fed as an infant also, interestingly, does affect what you have in your gut later on. And then there's things that industry is doing that may or may not affect it. We're sort of the bystanders of that. And obviously, antibiotics. Western diet is thought to be a big player as well. And then when you have these perturbations like antibiotics, for example, and you have decreased diversity in your gut, then you're also more susceptible to certain types of diseases. Need to get back over here? Okay. Sorry. Maybe I can shift this so I can run the computer without moving away. There we go. So as your diversity decreases, for example, probably the most clinical evidence for this would be a disease called C. difficile, which I don't know if you've heard of C. difficile before. It's not that uncommon in the hospital. If anyone has visited KGH, they may have seen this sign indicating a C. diff outbreak. So C. difficile is it's ubiquitous in most hospitals, and in fact, it's also in the community. So they think that maybe even 30% of people walking around in the community are colonized with C. diff, but they don't get sick because they have normal gut flora that protect them. But if you get antibiotics, you might actually end up with the disease. And the disease is much higher in the elderly population. And you can see this from this graph, where on the y-axis you can see how the inflection point is cut, and it's a fairly steep rise at higher age over 65. And this was data from about a decade ago, but it's basically continued to rise. So 20% of these patients actually will not respond to conventional therapy. So that means that out of every case of C. diff, 1 out of 5 will not respond. And so for these patients, they've established that they have much lower diversity in their gut than other patients that recover from C. difficile. And so one therapy, I wasn't sure if I should show this over lunch, but but it truly is the best example of microbiome therapy that works. So I thought I'll show the nicer version of the slide. And it's literally what it sounds like. It's a fecal transplant. So you take stool from a healthy donor that has lots of good bacteria in it. You infuse that into the patient with the recurrent C. difficile infection, and those bacteria then take, and that healthy flora then protects them against the C. diff. And I know this sounds crazy, and a lot of physicians actually thought this was crazy. This has been around in the medical literature since 1958, actually, but when the antibiotics that we use currently to treat C. difficile came out, that was obviously more palatable than going this route. So, the interest in this method shifted away, but now that the antibiotics are not working, we're kind of swinging back towards using these methods. And this paper came out a couple of years ago in the New England Journal. It was a randomized control trial, and I think this is really what convinced everybody, that it was worth looking into in more detail. And I'll just show you the reason for that is that if you look at vancomycin, which is the treatment that we usually use, the efficacy was 30%. So that means 2/3 of those patients did not respond. And with fecal transplant, cure was 80% and above. So there are not that many drugs on the market that have that kind of success rate. So that's why it caught everybody's attention. So that sounds really exciting, but we kind of wanted, at about the same time, we published a paper where we had tried to use a different approach where we developed sort of like a synthetic stool, if you like. So the idea was we would take the sample, remove all the pathogens, culture everything, look at what's in there, take out anything that we thought was bad. And I used a very simple approach for this. It was like, would I put this into my mother? If the answer was yes, we kept it. And if the answer was no, we took it out. So not very scientific, I'm afraid. But then we took what we had left and made sure that it held together as an ecosystem, because that's actually very important, that it works as a robust ecosystem, and then put it back into the patient. And we were able to show in humans that this works. And so to do this, we use this thing that we call a RoboGut. It's actually a continuous culture chemostat, and we can use, it sort of acts like an artificial colon, if you like, and it simulates the conditions of the distal human gut. And we use that to grow our bacterias when it's running. This is just sort of a close-up of what it looks like. And this paper that we published got a lot of interest both from the lay and scientific communities because it was sort of a way to move away from fecal transplant, which the FDA at the time was having some major problems with for obvious reasons. It's stool, it's not clean. So this was sort of our first success with this approach. And so I'm not going to get into all the details because I don't have a lot of time, but we're basically interested in a few different GI infections and diseases. So C. difficile, both from the fecal transplant literature and from what we do, we think the strongest clinical evidence exists for that. However, we're also interested in salmonella, and as well as other GI diseases, which I'm not going to talk about. But the salmonella, the reason that we are interested in that is that if you look at, so this is data from the CDC, not Canadian data, but they have a large database where they can sort of look at all of the infections on a year-per-year basis. And you can see here that in terms of the number of illnesses, hospitalizations, and deaths, actually, salmonella is right up there. In fact, it's number one. And I'm not going to spend a lot of time talking about salmonella because I have the master of salmonella sitting right over here. I'm sure she will tell you a lot more about non-typhoidal salmonella. But this is why we were interested in this disease from a clinical perspective. And so really what we're trying to do with our research program is to determine how these commensal bacteria in our gut contribute to protection against bacterial infections. And there's some evidence now emerging that these increased numbers of salmonella infection may actually also be due to antibiotic use because of decreased diversity. And certainly in animal models, you cannot get animals to get sick with salmonella unless they have received antibiotics before you give them the salmonella for mice. So there's some evidence in nature that this may be the case. And so we're hoping that if we can identify the species that are important, then similar to C. diff, we can come up with ways to protect people against these foodborne illnesses and maybe develop as a probiotic, for example, or as an ecosystem mixture that you take to help protect you against these sorts of things and develop therapies based on the microbiome. And I'm going to finish there. And
first of all, thank you for the invitation to speak briefly to you. I must admit, Slightly intimidating room for me. I bonded with Gary fairly early on when I arrived. But I guess I'll start before I get into what I'll talk about. I was speaking to Jillian over lunch, and I did not know very much about the Women's Giving Circle. My excuse is I've only been in Kingston for 6 months. But I think it's obviously a great organization that you've essentially created within the last couple of years to give research that actually stays within Kingston itself as opposed to goes elsewhere. And for someone like myself who's just starting, this is the kind of thing that is extraordinarily helpful to sort of get sort of the research program off the ground and running. If you're hedging your bets, you probably want to give it to Dr. Petroff or Dr. Martin, but I appreciate some confidence. So I'm going to start by talking about irritable bowel syndrome, which probably many of you have heard about in some form or context. And this is essentially the official definition, which is defined by the Rome criteria, which is a group of experts that smartly chose Rome as a place to gather to define a disease or a disorder. And essentially it's a group of symptoms, which the primary symptoms, there's two of them. One is abdominal pain or abdominal discomfort, and the other is sort of a change in bowel habit, whether people actually have more constipation or people have more diarrhea. And so there's a few little extra sort of caveats to this sort of definition. But personally, really practically, this is how I think about it. And that this is, when we come to our clinics, this is often what a patient will look like. This is what the physician will look like. This is what the nurse will look like. Everybody's in discomfort because it's really hard to treat. Sometimes we can have very good success stories with people. Other times, people keep coming back, and we just aren't able to get their symptoms under control. And so, just in terms of background, irritable bowel syndrome is quite common. If you look at some data, the pooled estimate is about 12% in North America, with that actually probably being higher in Canada, at least in some studies, compared to America. So it's estimated that about 5 million Canadians have irritable bowel syndrome. Interestingly, in all the studies that seem to look at this, it's more common in women than it is men. And it can be very costly. You think about direct costs, whether that be going to the emergency department, being admitted to hospital, prescription drugs, etc. This is a bit of an older figure, but you can see that per patient, that's $8,750. And that's not talking even about now your indirect costs, which you see in the last bullet point, which is talking about people who may miss work because of their irritable bowel. And it's estimated on average, an IBS patient will miss about 13 work days per year. And so part of our difficulty in treating is understanding what is the underlying cause of irritable bowel. And the reality is there's probably many causes, and it can be different for different people. And in this field, we often talk about this brain-gut axis. So as a gastroenterology person, I sort of acknowledge the brain being important and then leave it at that. But we know, as you can see on the sort of left-hand arrow, that there's stuff that happens within the gastrointestinal tract that can send signals to the brain, and the brain sort of perceives it, and people have pain and discomfort. Conversely, the brain also can send signals down to the gut. And so if you think of things like stress, anxiety, depression, these all can influence how the gut functions, and therefore can also influence the expression of various symptoms which come from the gut. And you can see that there are other factors within the gut as well that can all play a potential role, or have been shown or to play a potential role in the expression of irritable bowel syndrome. And so as Dr. Petroff talked about earlier, you have the gut microbes, there may be some inflammation that happens and then sort of resolves, but might be just going on at a really low level that is difficult to detect. We know that there will be changes in motility, so sometimes things will be moving along quickly, other times it will cause things to move along in the colon very slowly. You might have what we call a leaky gut, so things that don't normally stay in the lumen of the gut, now the gut's a bit leaky, and so they can cross into the different layers of the gut and cause all kinds of problems. The gut has a number of cells that can release hormones, and these hormones can signal to different cells, including nerves and cells involved in the immune system. So it's a real sort of smorgasbord, essentially, of potential reasons that people have irritable bowel. And for some people, there might be a predominant sort of etiology, and other people, it's a combination of things. And part of our difficulty is understanding what is playing a role for each either group of patients or each individual patient. And so in researching this, often what happens is in the lab, we have an animal model which tries to sort of mimic irritable bowel. You use this animal model to find a therapeutic target. That then moves quickly to the level of the clinic to see if this is now effective in patients who are in these GI clinics, and then it fails. So that obviously, that process is lengthy, but eventually it's costly, especially if and it gets to the level of clinic and then it fails. There's been a lot of investment into that. And so there really needs to be sort of a better way to try and have identify targets which we think may be successful in the clinic itself. And so what we're trying to do is sort of still use the animal model to sort of identify potential targets that may be important, but then have an extra step where we have more of a human model, which we call a preclinical model, where we're able to use human tissue to sort of see if that target we identified in the animal model seems to be applicable in human tissue. And if it is, then move that forward towards the clinic and hope that there's better success. Now, more recently, there's been a lot of sort of studies coming out and even press regarding sort of nutrients and their role in the expression of irritable bowel. And we've known for a long time, and if you talk to people with irritable bowel, there's a link between the meals they eat and the symptoms that they express. But we've really had a difficult time understanding this. And so one of the very new areas is this thing called FODMAPs. And FODMAPs is an acronym which stands for fructans, oligosaccharides, disaccharides, monosaccharides, and polyols, hence FODMAPs, because no one's going to remember how to say the rest of it. And so what happens is these are essentially are carbohydrates which don't get digested and absorbed in your small intestine, like a lot of the other food, and then reach the colon. And then those fancy little microbes that Dr. Petrov talked about that are in your colon can then ferment these undigested carbohydrates and produce things like short-chain fatty acids. They can produce gas, and that can cause increased sort of water into the gut and so on. And so there's been some studies just showing that if you put people with irritable bowel on a diet that's low in these FODMAPs, that they get improvement in their symptoms. But one of the things we don't know is we don't know why. We don't understand the mechanism of why that might be. And for someone to follow a low FODMAP diet in a very strict sense is very difficult. Because the easiest way to think about it, the things you like to eat are high in FODMAPs. And now you got to tell somebody you can't have them. So it's very difficult to sort of stick to that diet. Another area that's sort of gained recent prominence, at least in irritable bowel from the clinical side of things, is these bile acids. And bile acids essentially are produced in our liver. They get secreted into the intestine, and they really help with digestion, particularly of lipids. And they go down through the intestine, and the majority, up to sort of 95% of them, they get reabsorbed when they get to the end of the small intestine and get sent back to the liver and recycled. And so only a small number seem to get into the colon. But in at least the subpopulation of irritable bowel patients, more bile acids than normal seem to get into the colon. And we do know that bile acids can cause a bit of havoc in the colon, and they're not usually supposed to be there. But we don't understand all the mechanisms of that, and particularly we don't understand how they may potentially play a role in irritable bowel. Other than that, they're increased, and sometimes if we could try and bind up those bile acids, they might get some improvement in symptoms. So this is essentially a schematic of sort of the stuff that we're just starting up in the lab. So in the middle there, you have a segment of colon, and what we can do in a bath, in an organ bath, is we can put these things like short chain fatty acids or bile acids into that colon, and then we use an electrode to record from nerves that are going to the colon and see what happens to the activity of that nerve when we put those different nutrients through it. Does it activate the nerve such that it's much more active and therefore will send a greater number of signals to the brain, which may indicate to the brain that there's something abnormal happening, and then the expression of abdominal discomfort and abdominal pain. And then, as I told you, that there are other factors that might be involved in the expression of symptoms. And so when we begin to understand what happens if you just put the nutrient factors into the colon, well, now what happens to that signaling if we put in another factor which might be important, like stress? So under stressful situations, does this signaling now just absolutely go haywire, or change the way that the signal happens, and therefore we might get much more expression of symptoms like abdominal discomfort than in a normal situation. And then in doing that, we're sort of starting that in our sort of animal model, but again, we're trying to also move into more of, what we need to sort of understand is what we ever find at the animal model level applicable in the human tissue level. And so we're doing that in two ways. The first is people that undergo resection of a part of their colon for whatever reason, and oftentimes it's for colon cancer. With their consent, we're able to get a piece of tissue that the pathologist doesn't need to make a diagnosis, and we're able to record from nerves in those preparations, and again add those sort of nutrients and see as the mechanisms we found at the animal model also apply here in the colon tissue in humans. And again, like Elaine, I actually had a specimen that I was going to put up there, and I thought it wasn't the right time of day. And the other thing is, if you actually Google things like colon resection, it's bizarre what the things will come up on images, but that is actually a colon resection. And the second area that we will get human tissue is in biopsies, so from people who are undergoing colonoscopy. And I saw that a number of you visited our endoscopy suite at the Hotel Dieu Hospital a couple months ago. So I'm not sure, am I allowed to recruit people for studies? But you've been there, so you know how to get there at least. And so what we can do is we can look at people with irritable bowel, and we can compare them to people who do not have irritable bowel, and we can see what happens in those biopsies when we expose them to different nutrients. And is the way that the lining of the bowel responds to those nutrients different in people with irritable bowel compared to people without irritable bowel? And so essentially my long-term goal is to understand how these mechanisms of specific nutrient factors to start with express symptoms in irritable bowel syndrome. And then hopefully by identifying these mechanisms, then we can now look at sort of new therapeutic targets and strategies to help treat irritable bowel. Thank you.
What I'd like to talk about a little bit today is some of the work that I've been doing and will be doing a bit more of, thanks to the generosity of the Women's Giving Circle. My focus as a microbiologist is not so much on the host, as terms of us, but on the bacteria that populate us. And as Elaine alluded to, my favorite bacterium is Salmonella. And I think probably we've all experienced Salmonella in one form or another. This is just an artist's rendition of what Salmonella looks like. This was a glass blower who actually made this model. And so this is the body of the bacterium, and these long stringy things are flagella that help the bacterium move through the environment. So why would one be interested in Salmonella? Well, it's a really good model of what is called an intracellular pathogen. And that's a bacterium that actually needs to get inside of a host cell, not just inside the host, but inside a host cell in order to survive. And when we experience salmonella in our GI tract, often we experience an acute form of an infection that generally goes away on its own after a couple of days. We often don't think that much more about it. But you can get complications from being infected with salmonella. Not only can you suffer from infections whereby the salmonella actually crosses the intestinal cell wall and can become systemic. And this is especially problematic for people who are immune compromised or who have things like irritable bowel syndrome, where the protective layer in the gut is not 100%. But the other thing that we're coming to learn is that even up to a year after having a salmonella infection, we've been able to see that there's an increased incidence of things like arthritis and ulcerative colitis and various other things that I've listed here. So, that incidence of salmonella infection might have only have lasted 2 days, but a long time after that, you can still be affected by the fact that you've had that bacterium. And that probably has something to do with the effect of salmonella on the microbiome, as Dr. Petroff has alluded to. So I also was tasked with giving you an overview, but I don't listen to instructions very well. and I'm going to take us right down into the molecular level of things. And I'm going to show you pictures with a lot of details on them, but try and just focus on the sort of big picture as opposed to the details. So I'm going to talk about salmonella in the lumen, and then we're going to move from the lumen of the gut into how salmonella interacts with the cells lining the intestinal tract, and how it actually lives inside those cells. And I'm also going to talk about stressed salmonella. So David talked about stressed patients, but I'm going to talk about stressed bacteria and why they are important. So what I've shown here is just a schematic of the gut, and we can see that we have a lining of epithelial or enterocytes, epithelial cells or enterocytes, and we have various different kinds of cells that make up that lining of the GI tract. And interestingly, salmonella, which is shown here, has evolved to be able to get either into or across this lining of cells, which is pretty much a good barrier for many other things. So salmonella can either get across this barrier by entering through a group of specialized cells that actually do sample the lumen of the GI tract, but rather than being killed once salmonella gets to the other side, it invades other cells and lives fairly happily. The salmonella is also able to actively promote its own uptake into the epithelial layer, and I'll show you a bit more about that in a moment, as well as the bacterium can also trick cells of our immune system to actually reach out through this intestinal barrier and grab onto the salmonella and pull it across, and interestingly, the salmonella then invades this cell and lives happily in it. So salmonella really it's not specialized in getting in one particular way. It's evolved several different mechanisms. And this reflects partly upon how difficult it is to treat infections. And not only salmonella, but there's other bacteria that do the same sort of thing. So I'm very interested in understanding what it is that makes salmonella and some of the related organisms so adept at getting into and across the intestinal epithelium. So here we've moved on to the next step. And once salmonella gets into a cell, and this can either be an intestinal epithelial cell or enterocyte, or it can be other cells in the body, it actually usually exists in a vacuole, which it can sometimes escape from, and then it replicates. And soon you have way more salmonella than you started with, and a couple of different things can happen then. The salmonella can either the presence of the Salmonella initiates a specific kind of cell death. And the cell can either then release the Salmonella, and they can be passed on to the next person through the poop that's coming out of the gut. They can be cleared by mechanisms associated with the lumen of the GI tract, or these bacteria can then reinvade. So these cells become a bit of a niche for Salmonella to hang out in and replicate. While the Salmonella is there, this is also causing a localized inflammatory response. And so if this inflammation isn't controlled and dampened down, it can actually lead to complications as well. So it's a very, very complex situation in terms of what's going on when the bacterium is interacting with the GI tract. Okay, so this is the yuckiest slide that I'm going to show you. This is the most complicated one. But I wanted to show you this because this event here, this what's called triggering invasion, is what we're going to be using the Women's Giving Circle grant to actually look very specifically at. And this is a mechanism whereby Salmonella is able to cause cells to extrude part of their membrane out and around the bacterium, and then to pull the bacterium into the cell. So normally this cell wouldn't want to do this, but the bacterium is actually injecting proteins into the host cell that forces it to actually envelop the bacterium and bring it in. And of course, the Salmonella wants to be inside that cell, so it's doing its thing to get inside the cell. It can happen, as I mentioned, the Salmonella can escape from the vacuoles that it's in and start to replicate, or it can also take up residence inside a specialized kind of compartment and replicate within the cell as well. If this cell that Salmonella gets into happens to be a macrophage or something that travels throughout the body, this then becomes a little sort of airplane for Salmonella to go to different places in the host and infect different organs and perhaps cause a systemic infection. So there's a lot going on with this bacterium, and there's, even though we know quite a lot about how this works, we also don't know an awful lot. So what I'm going to show you now is a couple of short movies that look at the difference between a unstressed Salmonella and a stressed Salmonella. And when I say stressed Salmonella, we can do things to the organism that causes it to upregulate some of these proteins that make it much more pathogenic and much more invasive. And so by doing that, we can look to see what the phenotype is of those sort of interactions. So both of these panels here are just some cells that we've grown on a plate, and so they're laying down flat on the plate. And as I get these going, what you're going to see, so these are just time lapse, so there's actually about a half an hour or so that goes by here. So here you can start to see bacteria. So all these little things that are flitting around are the bacteria. And if you, there's going to be a couple arrows that come up in a second. There's one here, another one here. If you watch here, you can see a foci that changes its appearance. And this is that cell ruffling up and trying to capture the bacteria. And you can see it's a fairly dramatic thing, but the cell keeps sort of more, it's intact, it's just ruffling, and the bacterium is getting inside. So that's a bacterium that isn't stressed. Now if we take Salmonella and stress it, and then do exactly the same experiment shown here on the right, we can see that the cells react a little bit differently. So if we look where this arrow is, we can see that ruffling event right there. And the cell itself rounds up and usually actually detaches from the surface that it's on. And so this is there's a lot more going on inside these cells that have been infected with stressed bacteria than these guys over here that sort of take the bacteria up and are happy with that. So we're interested in trying to figure out what it is about stressing the bacterium that makes them much more adept at causing or being able to invade and causing pathology in an individual cell. And so the details of what I work on specifically is a mechanism inside the bacterium that's called the envelope stress response. And this is a series of molecular interactions in the bacterium that cause the upregulation of various different proteins that change the pathogenicity of the bacterium. And so there's a sensor component in the actual membrane of the bacterium that translates a message through to the genome and causes the upregulation of a protein that we're interested in called RDOA. And so this is our favorite Salmonella protein, RDOA. And we've been able to crystallize and understand the structure of RDOA. We didn't know what it did at all, but once we saw the shape of it and its structure, we could see that it was a protein that was called a kinase. And this kinase, and all kinases, actually act on other proteins. So they interact with many different other proteins, and they modify these other proteins, either inactivating them or activating or inactivating them. So we know now that we have a protein that can turn other things on and off. So that kind of fits with our story of if you have a lot of this protein that can do this activation, you're going to change the phenotype of the bacterium. So we've also been able to look at what happens if we get rid of this protein in Salmonella. And so what we've done is we've infected cells with wild-type bacteria and also cells that are lacking, bacteria that are lacking RDOA, and then measured how well they are able to get inside the host cell. And these data points up high here represent a high infection rate, and this is what happens with stressed wild-type cells. But if you take out the RDOA protein, we get much less invasion and much less survival of the bacteria. So even though we know so now we know that the RDOA is important in this stress response, and part of the work that we want to do with the funding from the Women's Giving Circle is to follow these up. So I'd just like to say thank you. Certainly from my perspective, support of research is critically important. And there's lots of things that research helps with that you might not be thinking about. And I think infectious disease control hasn't received a huge amount of funding over the years. We always think of cancer and heart and stroke and those sorts of things. So it's really lovely to see people supporting infectious disease research, because we have an enormous problem on our hands with the increase of antibiotic-resistant strains that are out there and continue to grow on a daily basis. And we don't have a lot of strategies that don't rely on antibiotics. So even if you go and you need a hip transplant or something like that, or a hip replacement or something like that, you need antibiotics in order to come out of that operation well. And the thought of our antibiotics not being effective anymore is not a comfortable one. And of course, control of pathogens is important in a way that leaves the good bacteria, the microbiome intact. So I'll end there and say again, thank you very much for the funding. The giant check.
So I'll just take this opportunity to thank Dr. Martin again, and to all three of our presenters. I think we give them a bit of a challenge to be able to explain their research to a group of women who are not medically trained and might not be able to pronounce even the words that they're talking about. So thank you. I'll turn things back over to Jillian.
Please join me in showing appreciation for their presentations of our 2015 grant recipients, Elaine, David, and Nancy. We hope that in the future you will keep us informed of your successes in your research. Special thank you to the chef and staff of the Donald Gordon Center. I guess they're doing their thing back there. And I would like to again thank our sponsor from Shoppers Drug Mart for making today possible. We hope that you've enjoyed this very informative luncheon. We're always looking for